Yeah. Good morning and welcome to classroom. Today we have got a very interesting case. Also, an extremely talented faculty from Cleveland Clinic. I welcome Dr. Shobana to classroom today. Hello, madam.
Hello, good
Hi.
morning.
Thanks for joining us. She is a staff anesthesiologist as well as associate program director for the Neuroanesthesia Fellowship program at Cleveland Clinic. Thanks for joining, madam.
Thanks for inviting me for this program. I really appreciate all of your efforts in trying to improve education in neuroanesthesia.
Thank you so much. And the case is very interesting. Let me put the case in context. It's a middle-aged man. He has got history of obstructive sleep apnea. The history goes like this. About 1 year, he had problem word findings. He has spells on seizures. He was MRI showed a left atrium and he was found range dominance. We all know that awake craniotomy is commonly practiced in areas where in eloquent areas, tumors where the surgeon has to resect with minimal disability. But this is a special scenario where they've got an MRI suit as well, and the surgeon want to utilize the MRI suit to be as safe as possible and to remove as much as tumor as possible. So it's a very interesting scenario where an awake craniotomy is being done in an intraoperative MRI suit.
Mhm.
Let Why do you want to combine MRI with awake craniotomy? What is the advantage? What is the benefit?
No, that's a great
Over to you,
question.
ma'am.
Yeah, that's a great question. Like you just mentioned, awake craniotomy is done when an eloquent part of the brain is at risk, which means it's a part of the brain which probably controls an important motor component or sensation, or maybe language, speech, and memory. And but in order to maximize the safety of this procedure, nowadays there's a trend to do all these cases in the intraoperative MRI suite. That is, they combine MRI and do awake craniotomy over there. This is basically to increase precision and accuracy. And nowadays we are doing more and more of these cases. I'd like to actually share my screen now to
Yeah,
show
sure, ma'am.
you. Um, I
Yeah, you
haven't
can
gotten the
start
share.
sharing.
Yeah, I'm trying to get to the share screen part. It's not showing up, but um, it's on the left, right? The share screen button.
Yes, yes, madam.
There's a green.
Yeah.
Yes.
Okay. Yeah, I got the screen
Maybe
share button.
it will be less responsive. It might take some time.
It'll take some time. Yeah. Okay. So I'm
So
sharing
awake craniotomy is
right now.
being done.
Yeah.
Yeah,
Yes,
we can
madam.
share. We can see the screen. Yeah.
Okay. Yeah. So, as you know, all know, I'm from Cleveland Clinic. So, as you were talking about MRI and awake craniotomy, I just wanted to show you this picture where you have this is a dedicated IMRIS suite. IMRIS is basically a company which stands for Intraoperative MRI Guided Surgery. Can you see my screen?
Yes,
Yes, ma'am. Yeah, very much.
Okay. It integrates the surgical suite with an MRI scanner. And as you know, nowadays more and more surgeons are using neuronavigation to improve the accuracy of tumor location. But sometimes once they start the surgery, there can be brain shifts once the dura is open. And sometimes there can be bleeding and other problems. And for that reason, when you also add the MRI along with this, precision and accuracy does improve and ultimately leads to better patient outcomes. There have been multiple studies actually coming in which show that with low-grade tumors like gliomas, the recurrence has been drastically reduced when you use this combination of MRI and awake crani. And as well as in high-grade lesions, the survivability has been extended. And this is probably one of the reasons why surgeons are now using more and more MRI. We actually do at least 3 to 4 cases, not awakes, but 3 to 4 cases with intraoperative MRI these days. The indications for surgery in the MRI suite are expanding, and it's not only for brain tumors, but they also do neuroablation, Stokagen therapy, epilepsy surgery, deep brain stimulation surgery. But when you consider awake craniotomy, it is mainly done for brain tumors.
So, craniotomy in MRI suite, I think there are a lot of problems in that. Even awake craniotomy, yeah, as you said, is very commonly done, and different people use different techniques, and everybody claims that it's successful in their hands. Some may use scalp blocks, some may not even use scalp blocks, just with local infiltration, they do the case. Some centers practice a sleep awake, a sleep technique.
Right.
Some centers, they just do it under monitored anesthesia care with light sedation to deep sedation, depending upon the scenario.
Right.
But combining with MRI, yes, it has its own problems. So, what are the common problems which you face when you combine an awake craniotomy in an MRI suite? Definitely, there are problems. So, what are the common problems you face during this?
Yeah, another important question. First of all, I want to say that our MRI, or most of the time, MRI locations are many times in the basement of the hospital where radiology is usually. And therefore, this is a place where you are alone and you have to handle whatever complication arises. It's not like you have someone whom you can call and they can come there in a few minutes or like as quickly as possible to help you when there's a problem. Again, I'm going to share my screen with you to show you some more slides. So I did mention that this is a remote location, and then there's a powerful magnetic field that is generated by the magnet itself. So any metallic object can act as a projectile, and this can harm the patient as well as a personnel in the operating room. Therefore, it's very important that you do not that there can be no needles and no other not you cannot use the routine monitors that we commonly use in the ORs. Besides that, you can't bring in pagers and cell phones, and all these will make us a little more unfamiliar and a little more uncomfortable, I guess. And if you see this gray line, that is the 50 Gauss line, and all your monitors, the bear hugger, the IV pole, and infusion pumps need to be outside this line in the surgical suite. Besides this, as I told you, the monitors have to be different. They have to be MRI safe, and many of us may be unfamiliar using these monitors. So once the familiarity increases, I think we can get more and more comfortable in this area. MRI also induces heating in the monitoring cables, and therefore you need to have adequate padding between the patient and these monitoring cables. Otherwise, there can be burns in the patient. Besides that, the MRI, when they're scanning, does generate a high degree of noise, and this can induce acoustic problems. And therefore, you need to make sure that the patient, as well as the personnel in the operating room, have ear protection with like some earbuds or something when the scanner starts. Again, as far as the infusion pumps are concerned, they may become very unreliable if you keep it too close to the magnet, and therefore it has to be on the gray area or slightly outside. And also make sure that the pumps are securely attached to the pole. Otherwise, they can get dislodged and fly towards the magnet. If you look at these EKG electrodes, this is how we place them all close to each other, unlike the normal way of placing them. And this is in order to increase the amplitude of the EKG signals. If you see the electrodes, the cables are also really short, and we use remote monitoring, that is basically wireless monitoring. This again, as I told you, because all these long cables can generate heat and cause burns on the skins of the patient, and that's the reason why we use all these remote monitors. The other thing is, because of the electrical noise that is generated by the magnet, there's a baseline fluctuation in the EKG signal, and therefore you will not be able to detect ischemia or any arrhythmia. And these are all some of the shortcomings when you have to do the case in an MRI suite. I just want to show you the picture of how this surgical suite is laid out. You can commonly divide them into zones 1 to 4. Zone 1 is the zone where everybody can have access, the patient, their family. Zone 2 is the anesthesia induction room, which is this light orange area, if you can see on the left side of the screen. And this is where the patient is induced. And once the patient is induced, like suppose it's an awake craniotomy, we do all the lines in the induction room, and the patient is sedated in the induction room, and then they're transported to this point where you can see it says checkpoint. And that's where the patient, as well as all the personnel, are wanted. All the personnel, and of course the patient, has to be screened that they don't have any pacemakers or any aneurysm clips or anything metallic inside. And then after this, they're then taken through the scrub room into the surgical suite and then onto the operating table. And if you can see, and the red areas are where the magnet is most powerful. And there is a door between the MRI and the surgical table. And only when the scanning is necessary, the MRI machine comes out and the patient is scanned, and then it goes back inside. So did you want to go ahead? Do you have any other questions? Or
I have 3 other faculties with me whose institute also has got an intraop MRI.
Sure.
I just asked them briefly about now what are the process, and then we'll carry on. I'll go to Bangalore, and he has got an MRI facility as well in this center. Dr. Gopal?
Yeah, sir. We also have a intraop MRI facility. The thing is, we have we call it as next door intraoperative.
Certain problems.
No, the voice I'm not able to. It's breaking, sir.
Right.
Yeah.
You carry on. You go ahead.
Yeah. We have a intraop MRI. We call it as a next door intraop MRI. We use it for OPD basis also, and sometimes we use for intraop cases also. So the thing is, like we usually use under anesthesia. Awake, we have never done a intraop MRI. The thing is, the table, like the dock, will move on to the transport trolley, which is MR compatible, and we push the trolley into the MRI gantry. It is next door only, and we get the MRI done, and patient is taken back to the OT whenever the MRI is required. So this is,
you take the patient outside the operation theater into the MRI, or you have a partition?
It's outside the operation theater.
Okay, it's like shifting the patient and getting him back.
Yeah,
okay.
Shifting the patient to the next door. Next room. Yeah.
Oh. So not very far off, but.
Yeah, it's a next room where two OTs are connected. Two OTs are connected to that intraop MRI. So whichever OT they are doing, that table, that OT, that patient will be shifted to the next room.
So do they do
Dr. Ashish?
partial closure before?
How do you do?
While we have a MRI suite which is purely for the surgical cases only, so it's inside the OR. So the zones are divided like zone 1, 2, 3, as Madam told, but the designing is such that the MR machine is stationary only. The patient and its table moves inside the MR machine, and we use a intraoperative. So we have done a lot number of cases with awake with MRI, and now the thing is, yes, for increasing the cost effectiveness of the suite, we do take up the cases in the morning or in the odd hours, which are for the pre-operative MRI scans, and the MRI scans are also stored in the same machine. So next day when you are taking up those patients for surgery, then we use the same scan, so we don't need to load them again. But ours is the complete OR MRI suite with a table and intra-operative MRI, and the gantry doesn't move, the table moves inside the gantry.
All right. So now I'll go back to Dr. Shobana Rajan. Madam, how do you go about with this case? Okay, the patient is posted for an awake cranie. So what is the technique? How do you do this case? And also I hear that this patient has got an obstructive sleep apnea and bit obese as well, which are sometimes conventional contraindications for awake craniotomy. So how are we going to do this?
Yeah. So it's a more difficult case than regular. So this is Mr. XY. He had history of word finding difficulty and spells of disorientation and history of seizures, and his functional MRI showed a left temporal neoplasm with left-sided language dominance, and therefore awake craniotomy with language testing was planned. Now, when you looked at the preoperative assessment, many times patients have a number of comorbidities. They could have atrial fibrillation and could be on beta blockers. They might have been on anticoagulants, hypertension, hyperlipidemia, diabetes, and most importantly, obstructive sleep apnea, which is what is most alarming for us, isn't it? Especially when we have to do it as an awake craniotomy. You look at the weight, he's pretty much above 100 kilograms. The body mass index is high, and you looked at the airway, and that shows a Mallampati grade 3, and so these are all makes you thinking as to how we're going to do the case. So it is done in 3 phases. Like, it's the initial phases are where a sleep phase, where you have to keep the patient well sedated for the induction, transport, and then pinning, and then opening, and then you wake the patient up on the pins and test the patient, and then again you have to put the patient back to sleep when you do the MRI scanning, and then during the closure. So it's very, very important. I cannot even tell you how important it is to have patient trust at this point, because they need to know that we're going to obviously take extremely good care of them and be very cooperative. So let's just look at this huddle.
Dr. X, your surgeon. We're here for an awake craniotomy for tumor resection, and this is a safety huddle. Can you please tell me your name and date of birth?
Yes, my name is Mr. Y, and my date of birth is 22/2/2022.
Are you sure about that?
Yes.
Okay. Can you tell us what we were doing for you today?
You are going to have fun removing tumor from my left.
Great. We have a wonderful team for you today.
Hi, I'm Dr. R, your anesthesiologist.
Hi, I'm Miss B, your scrub nurse.
All right, so we'll go to sleep for the first part of the procedure. We will pin the head turned to the right and the left shoulder up. Once the dura is open, we will wake the patient up on the pins, which will be followed by testing and tumor resection. You can put the patient back to sleep for the MRI scan to check for the adequacy of the tumor resection, and we will resect more if necessary. If not, we will close and wake up. Do you have any questions?
No.
So most important in this case is the different techniques of airway management. I guess that's the primary question is, what are we going to do? Are we going to just keep the patient with a nasal cannula, or should we put in a more invasive airway? And I'm sure that all of us have like differing opinions for this. If it was just a routine case and the patient wasn't obese and did not have obstructive sleep apnea, possibly we would just sedate and just use a max safe nasal cannula with or without a nasal trumpet if there's obstruction, and go ahead. Now, you could potentially give CPAP through the nasal trumpet. Suppose you have a obstructive sleep apnea patient with morbid obesity, then what we do is put in an LMA for the asleep phase, and then during the awake phase, you can take it out. Now, if it's a very difficult airway as well as morbid obesity, then we may think of actually intubating the patient, do an awake fiber optic intubation with airway blocks, and possibly do it through the nose and pull it out up to the nose during the awake phase. And this has been described in literature. For this patient, we would choose LMA for the sleep phase and then take it out. I just want to show you some pictures of how we would handle the airway. So you could put in a nasal trumpet after putting in some nose drops, like phenylephrine nose drops, to make sure there's no bleeding. And then you can put in an oral airway as well and monitor CO2 through the oral airway and give oxygen and insufflation through the nasal airway. You could also put in a nasal trumpet and then monitor EtCO2 like that, and administer oxygen through a face mask if you think that the patient requires a higher amount of oxygen. In an obstructive sleep apnea patient and you decide not to put in an LMA, in that situation, you could potentially put in 2 nasal trumpets, and then you attach it to the double lumen connector of a double lumen tube, and then you can actually give CPAP through this tube. So that could be another option as well. I was wondering what drugs do you use and what do you do in these cases?
I'll go to Dr. Ashish. What is your technique in these kind of
Well,
patients?
for patients with OSA or obese patients, or otherwise, we are most comfortable
In general,
in
otherwise, yeah.
general. Okay.
No,
We
do
are more.
you take up OSA as morbid obese patient for these procedures?
That is what
Usually,
I
they are
was
conventional
wondering.
contraindications.
Yeah, they are conventional contraindications, and not many people have those kind of guts to take these patients in OR. But if it's absolutely indicated, that then yes, we do take obese patients for awake craniotomy. Though I haven't taken, I strictly remember a patient who was to be planned for awake craniotomy in MR Suite, and the patient was obese and he had a short neck also. So we were actually worried whether to take up this case. Then I discussed with the surgeon if it is dire necessity to take up in the awake craniotomy, since we were doing a tectography and MRI intraoperative also. So once we decided not to take up this patient for awake procedure, and once we also did in awake. So generally, what as a protocol are we go for conscious sedation with the scalp blocks. This is the technique we do for all awake craniotomies. So after putting, we generally use now after introduction of Dexmed, though we have a good literature of our center only, where we used Propofol earlier for awake craniotomy while giving the scalp blocks. This is our general technique, and if I particularly talk, then after the introduction of dexmedetomidine, we are giving scalp blocks under dexmedetomidine sedation. And like Madam has used nasal trumpets for delivering oxygen cannula, and for ETCO2, we do similar things. We put in
So you don't do the asleep awake asleep technique?
No, we don't do. We do scalp blocks with conscious sedation.
Okay.
Right.
Dr. Prasanna, what is your technique usually in awake craniotomy?
Absolutely, it is almost same. So only scalp block and dexmedetomidine sedation that to titrate it. So even
So you also don't use the sleep awake.
No. Totally, it is awake, and even the dexmedetomidine, I am trying to come down on the dosage what I give to the patients. So I want completely awake even in the intraoperative period. So because particularly when the patients are old, like 60 years or so, longer infusion of dexmedetomidine also can lead to some amount of cognitive assessment difficulty. So
your patients are very comfortable while block in the dexmed infusion?
Yes.
We load
It's all about explaining the patients. It's about 4 to 5 pricks or maybe 8 pricks, but it's all about explaining the patient that it is vital for you and it's better to be awake.
So it's only dexmed, or you give some opioid as well?
Just dexmed.
Just mostly dexmed, and if at all I am using fentanyl, not more than 20 mics. Yeah.
Do you load or you don't load?
I do load.
We also load.
1 mic per kg bolus, then followed by, I start with initially 0.5 microgram per kg per hour, then either step up or step down. Mostly I step down. Generally, I don't go step up.
Most of the times when we use dexmed, unlike propofol, when you stop propofol, kind of the clear might be missing. Patient must be sedated during an awake phase. So do you feel that, or you are very much comfortable in this?
Yes, ma'am.
In our hospital, we usually do combination of. Was I interrupting somebody?
No, ma'am. Continue, please.
In our hospital, usually we do a combination of propofol as well as dexmedetomidine. We do load most of the time with 0.5 mic per kg per minute of dexmedetomidine, followed by 0.5 mic per kg per hour of dex. And we continue, and we start off slightly higher with propofol, like 75 mics per kg, and then we cut it down to about 50. And we find that propofol is really reliable, and but it is a respiratory depressant, whereas dexmedetomidine does not have the respiratory drive suppression, and it supposedly doesn't have much effect on the ICP. It's neuroprotective, they say. So when we found that when we do a combination of both of them, you have the patient totally asleep. At the same time, the patient is breathing. Hemodynamically, they are stable. So we've had a pretty good experience using a combination. We don't use any midazolam, but we do 25 mics fentanyl, maybe when we put the art line, and maybe when they're doing the pinning, if necessary, we do that.
Okay, combining Dexmed and Propofol, what are the effects in hemodynamics which you usually face, and how do you manage that?
Yeah, it's a good question. To be honest, only with the low bolus dose of dexmedetomidine, I've had some problems. When I did 1 mic per kg as bolus, sometimes there's sudden tachycardia and hypertension. And sometimes there's also severe hypotension. But ever since we've been using the 0.5 dose for the bolus and then using this combination, it's a very carefully titrated combination of 0.5 of dex, 50 to 75 of propofol. And if at all necessary, you can give 1 or 20-30 milligram bolus propofol at the point of like scalp block or pinning. And we've never had any hemodynamic or respiratory issues. Small respiratory issues is easily amenable to correction with some jaw thrust, putting in a nasal airway, increasing your oxygen flow.
Okay. Because you were mentioning about how do you titrate? Do you monitor routinely?
Sorry, I didn't hear. Are you talking?
You use set line in these cases?
Depth of anesthesia monitors.
We don't do any depth of anesthesia monitors because they cannot.
Because you said you will be carefully titrating the drug.
It can only be done a clinical titration and make sure the patient is asleep, because you cannot basically take all the SED line or the BIS monitor inside the MRI suite, because I don't think they are MRI safe and compatible. So and you can't put those stickers on the forehead either. I don't know if it has any metal in it, but it's only a clinical titration. You can see that the patient is asleep, is not responding to surgical stimulus. So you know he's asleep with the IV medication. And you're not paralyzing him, so obviously you do know he'll move if he does have any pain.
All right. You said you will be taking so what are the monitors? Because some of the institutions, they don't prefer any invasive lines in these patients. So you said you really take A lines and
totally
CVC as well.
Sorry, what was the last thing you said?
It's central venous catheter as well.
No,
CVPs.
Okay.
No, we don't do CVPs, only art line. We think it's absolute must, especially if you need to know the ETCO2 may not correlate with the PSCO2. The surgeon may say the brain is bulging. You want to know what the PSCO2 is. The ETCO2 may be different. And even otherwise, we have diabetic patients. You may want to check the blood sugar. You want to look at the lactate levels at some point, or maybe hemoglobin if there is a lot of bleeding. So we definitely put in A lines for brain tumor resections, especially awake craniotomy in the MRIS suite. I don't know if you feel differently about that.
Go to Dr. Ashish as well. Okay.
Yeah.
I'll ask Dr. Ashish, what are you take routinely arterial lines and
so
do you use a brain function monitor?
Well, if we are in a MR suite outside the 5-gauge line, we sometimes use for titration of sedation the BIS monitor, but specifically if it's a planned MRI intraoperative, we don't use a BIS monitor. But it's a routine habit to use a BIS monitor for intraoperative titration of sedation in awake craniotomy. In an MR suite, there are specific ECG electrodes. When moving the patient into the MR, we use those electrodes which have a short wire so as to avoid the thermal injury. Outside the 5-gauge line, we have MRI compatible monitors with their own ECG electrodes. And then we use a NIBP. We put A line in all our patients, which are being taken for a
in all our patients.
Yes, in all our patients, because I agree with ma'am completely that we do need to trace the ETCO2 and other things, and I think some comfort associated with arterial monitoring. It gives us lots of confidence that okay, the patient we can manage whatever is happening. We don't go for CVP lines generally in awake craniotomies. We go for urinary catheterization. And that's it. This is what we do. Invasive lines just a line, no CBPs. Yes, but it's
Dr. Prasanna, what
No, I don't even use
do you do the
arterial line.
same or you do
No,
something different?
no, it all
Okay.
depends on the tumor. If your tumor is a little bit bigger, then I use arterial line. Otherwise, I don't use even arterial line. 2 IV cannulas is what I use routinely. If it is a 2 by 2 centimeter tumor in a eloquent area, I don't expect a brain to bulge, even because of little bit of CO2 rise or even if a PCO2 of 50. So I'm not too much worried about that. So I don't use arterial line, except a tumor, suppose it's 4 or 5 centimeters something and near to sinus, or then the maybe case I will use. Otherwise, routine small tumors, I don't use arterial line.
Okay. Maybe I'll go to Dr. Ajay and find out now what is his technique. What do they do in their institute and what are this, Ajay?
So in our center, we routinely go for dexmedetomidine based sedation. So we give a full loading.
Only Dexmed or you
Yeah,
combine with some other? Okay.
there are two techniques. Some of our consultants go for TCI based propofol. We target around Snyder model 1 to 2 mics target, and others like I routinely go for dexmedetomidine, and we give a loading. And the main thing is we should not disturb the patient when the loading dose is going on. Only once the full loading dose has gone, only we'll attempt the scalp block and the invasive lines, and we let the patient go for a nice deep plane of sedation, and then we go for the scalp block under the dexmedetomidine cover, and under local we put the art line, and we also put a PICC line depending on the size of the tumor. We have peripherally inserted central lines, so we go for PICC line. Especially if you are going for TCI pumps and all that, PICC line helps. And if you are going for propofol based sedation, we use a BIS monitor. And if it is dexmedetomidine, we don't use this because it does not actually correlate much because it's subcortical. So there is not much of benefit we are going to get from our dexmedetomidine. So that is how we do it, and we continue the sedation till the surgeon opens the dura, and once that we stop the dexmedetomidine. If it's propofol, we wait for another 10 minutes before the neuropsychologist starts the assessment. And another thing I would like to add is I would like to stress on the scalp block. It should be anatomically blocked individually. The nerve should be blocked. Some places they go for a ring block. Some centers they go for a ring block, which is not really effective, especially when the temporalis fascia gets pulled, the patient will start complaining of pain. So it should be a proper scalp block, not the routine ring block. And also, it's better if we add adrenaline because we get a longer duration of action. Because our center, the surgeons do take a bit of time. It's not like 2 hours, 3 hours. They routinely go for 4 hours at least. 4 to 5 hours it will take in our center for awake craniotomies. And I have two questions to ask Shobana madam. I saw in your picture that you have inserted a oropharyngeal airway. So how did you manage to
Manish
avoid
opinion
the
as well.
gag on that patient in awake patient? Or do you
Yeah,
insert
that
it
was
after
when
the
the patient is asleep. Yeah, after the propofol and the dexmedetomidine.
Okay, and another question is in that difficult airway scenario, you said you were going for a fiber optic intubation. But how safe are you during when the patient re-emerges during the awake phase? Like, have you encountered any difficulty, like if the patient has a respiratory embarrassment, how are you going to manage? Do you have a plan B to put the tube back or anything like that?
Potentially, if you want to put the patient back to sleep after the awake phase is over, you can again put the fiber optic through the tube, which is now at the level of the nose. You can actually push it back into the through the vocal cords. This would be very difficult airway situation only. Even in a generally obese patient, you would probably just do an LMA.
Ajay, these are some of the rare scenarios where you get. So it's all the individual comfort and the experience of the.
How madam managed to
Well, that wasn't a real patient, but I just wanted to, we put in a mannequin just to show that that's a potential backup plan in a difficult situation.
Yeah, I'll go, Dr. Dr. Manish.
Yes, Manish, your views on
Technique.
this.
Okay. I have tried both. Actually, in AIMS, we all used to do awake, and in my own practice, I started doing sleep, awake, sleep, and I feel that sleep, awake, sleep is more comfortable for the patients and for the anesthesiologist as well. Because when we do awake, the patients usually get tired during the monitoring phase. They start complaining that it is taking a long time and they are tiring. Also, for us, it is slightly difficult because sleep awake sleep, we just make put an LMA, give the blocks, and the surgery is started, so that the time taken is slightly less. When we wake up the patient is usually fresh, so that he cooperates in a better way. And in the end of the monitoring phase, we again put LMA and make the patient sleep, so that in my personal experience, because I have used both the techniques, I feel that sleep awake sleep is more comfortable for the patient. Secondly, I do usual induction with LMA, with propofol and fentanyl, and then give the blocks. And in the awake phase, I stop all the agents once we determine that now we want to do the testing. And again, when we want to put the patient to sleep, I just give propofol and put an LMA back and use inhalation technique with dexmed infusion.
Does anybody use remifentanil infusion?
Oh, I'll go to
We
Dr.
don't
Not
have.
available.
No, it is
We
not
don't
yet
have.
available in India. Yeah.
Okay, got it. But do you use inhalational technique sometimes, like Dr. Manish said, you use inhalational when you put in an LME?
Yeah, I use fentanyl with it.
Mm.
And one thing is with propofol, what we have noticed is they have some kind of paradoxical agitation as the inhalation goes along. I mean, they get more agitated towards the end of the, I mean, during the assessment phase and towards the end of the procedure. So that is one where a point at which dexmedetomidine scores. But some studies have shown that intraoperative seizures are less with propofol. I mean, personally for us, we haven't noticed intraoperative seizures in either of our groups.
Okay.
That was our study, a retrospective analysis of some.
I'll go to Dr.
Yeah, one was there with.
Right.
Different. They do a technique which is very familiar to them, and everybody said that it's working for them. So whatever may be the technique, certain problems which will shoot up in. How do you troubleshoot that? Saturation. Patient can have a rhythm. So how do you tackle that?
I'm going to continue with some more of my slides, and I think we could go ahead with some of the troubleshooting things. So for one thing, I wanted to mention that during testing, it's so important to keep ice cold saline available in case seizures happen. And then when we go back to sleep, we normally put in an LMA, because this is how we wrap the patient up. So to go into the MRI scanner. And so it's really important to make sure that the patient's airway is secure. And that's one of the reasons why we put in an LMA. And we also have very diligent checklist before we do the MRI scanning, making sure that all our drugs and syringes and everything are put back into place. Say, for example, the temperature probe, things like that. Make sure the bear hugger is outside the 50 Gauss line, etc. And then this is our magnet. I'll just show you our magnet, and then we can go back to some more troubleshooting.
You look good. Okay, walk it out. Try to not get in the view. Bum, 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 bum.
So this music was just for fun. One of my CRNAs, he was the one who recorded it with the music. But you can see that it's so important to make sure that there are no kinks in your breathing circuit or disconnects, and you have to make sure your peak airway pressure is normal because everything is under the drapes. Make sure your IV lines are working and there are no kinks with that. You have to have really long extensions. And even your ETCO2, the ETCO2 line is going to be so long that by the time you detect a disconnect or any change, it's going to take a few breaths. So instead of monitoring the monitor many times, we have to be very vigilant and monitor the patient. And as Dr. Ponniah was talking about various problems, I'll just quickly go through the problems and then again we can have a discussion. So if there's a problem for drop in patient saturation, in the asleep phase and the airway is now obstructed, we did a study where we compared patients undergoing awake craniotomy with sleep, and we found that many patients did desaturate to about 94 to 90% saturation. At that time, all you need to do is do some simple measures like we all know, just lift the jaw up, maybe try a different airway, increase the oxygen flow, decrease your sedation. So there was really no complication, and therefore awake craniotomy can be safely done. Another problem is the surgeon may say that the brain is tight and the ETCO2 is high and he wants it, to 28, and then it becomes our responsibility to tell them, see, this patient is asleep, you can't hyperventilate. But then things you can try is increase the head end of the patient, make the patient reverse Trendelenburg, and you could potentially give mannitol or hypertonic saline, and also decrease your level of sedation could potentially help. And that's where I think dexmedetomidine scores, as you were all mentioning. The other problem could be that the patient is not waking up for the awake phase. And this is when you have to think about the context-sensitive drugs that you've given. In general, I've noticed that when you do propofol dexmedetomidine combination with no Versed and very minimal fentanyl, patients usually wake up in 15 to 20 minutes. So I usually tell the surgeons, please let us know before you want the patient to wake up and give us at least 15 minutes time to wake the patient up. And there have been some instances when the patient hasn't been waking up. It could have been that the patient has severe vasogenic brain edema or a bigger tumor. And in that situation, there are times when we have reversed their fentanyl with naloxone. But again, very, very rare. I guess we can do nothing but wait it out. Patient could potentially have seizures, as I mentioned, keep ice cold saline available, especially during cortical stimulation. This could potentially happen, but we always give the patient Keppra, keep phenytoin in the room, and and avoid this complication. Another important thing that could happen would be if a patient violently coughs, has tachycardia, hypotension, what do you think is going on? And many times we may miss the venous air embolism diagnosis, and you have to watch the ETCO2, hemodynamics carefully and see if the surgeon is actually working on maybe a dural sinus, which is now open and entraining air. And most importantly, at this point, we make sure that the patient is not breathing too heavily, because that can actually entrain more air. So I would definitely say the anesthesiologist has a great leadership role in orchestrating the MRI environment. And it's really a long surgery, and with testing, scanning, exhausting for the patient as well as for us. And we have to promote safety to minimize complications. Yeah, I'll go back to you all to tell me your views.
Enumerated all the issues which can happen.
Yeah.
Brain tightness. People are, how do you BP in the environment of I do BP cable which is compact? I think you should be also having that. People are not asking that, is there a transduced disease? I think it's available. BP monitoring, isn't it? The MRI phase as well.
I'm sorry, I wasn't able to hear you.
Yeah, over to you, ma'am.
I wasn't able to hear you because there was a lot of
Okay, I'll repeat it.
disconnect.
Okay. Network connectivity. There are
Yeah.
a lot of happening in our live chat, and people are discussing about an arterial line inside, and there are answers which are available of that, and they would like to know you monitor in the environment.
Okay, Ponniah, we are not able to listen to you.
That they
Ponniah.
would not dare to.
Okay, I want to present two interesting scenario which came or which
Dr.
I
Prasanna,
encountered.
you just carry.
Hello, am I audible?
Right, you are.
Okay, okay. I want to
Carry
present
on.
two different scenario
Now,
which came to my practice. One was a case where we were doing awake craniotomy for the tumor was in speech area, and now the patient was speaking during the monitoring process, and all of a sudden he developed slurring of speech. I mean, he was probably losing his speech. At that time, we stopped, and the surgery was concluded there. But I want to ask how you judge where to stop, because sometimes the damage has already been done. Like in this case, although the patient developed some deficit in immediate post-op period, but eventually he recovered from that speech deficit. So the question is that in awake craniotomy, does this technique tell us before the actual damage has already been done, or sometimes we may be slightly late for doing any intervention?
No, I agree. That's quite an important question that you raised. Whatever I've seen, the tumor has been close to the speech area, and whatever I've seen, they've avoided the speech area. I haven't actually seen anybody who had a speech arrest or a problem like you're mentioning. And so I'm not really sure what we should do. Like you said, if the damage is already done, I guess we have to stop at that point. Potentially, we could scan again, use neuro navigation, and I think these are all more of neurosurgical techniques. So I'm not really able to answer that question accurately. But I agree with you that if there is already speech arrest, then it's possible some amount of damage may have been done. But maybe the edema, once it subsides, as you said in your patient, the speech came back, so it could potentially come back also. I don't know what other people feel.
Am I audible now?
You are.
Okay, thank you. It's raining in Chennai. Maybe some kind of disconnections in the network. Now, what I was telling is there is a lot of discussions which are happening in our live chat, and people are wondering whether do you have a transducer to measure the arterial pressure?
Yes,
MRI,
we do.
and I think, yeah.
It's a good question. Yes,
Yeah.
we do have
The
a
other
separate
is
special
that
test. It's different
the
from the
MRI
regular one. Yeah.
for yeah.
Yeah.
Yes, the MRI compatible
And
monitors do have arterial transducers. They have transducers. We have MRI compatible machines with transducers.
Right.
Anesthesiologist MRI. All can happen during this case. And
I think we're not able to hear Dr. Ponniah, I think.
I think everybody.
Okay, I want to ask everyone how they how frequently they test like power of the patient or speech of the patient. We are doing the awake craniotomy like in the patient where I told you the speech was being tested. We asked the patient to sing a song and suddenly the tone of the song changed. So that how frequently do you every 5 minutes or every 2 minutes or how do you manage that?
In our patients, they do it continuously. They tell the patient, say 1 to 10. So the patient keeps saying 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Then they keep on talking to the patient. They show them pictures and they ask, do you know what this is? Is this a pen? Is this a cat? Is this a cow? So they show them pictures. Then they ask them other questions, then they say, show me your tongue. And so they keep on asking different type of questions, but it's usually continuous during the awake phase, during resection.
How Dr. Nitin, how you are doing it?
In our place, actually, the neurophysiologist will be present, and she'll be like continuously in chat with the patient. Depends on what area the surgeon is operating on. If he's on the Broca's area, there'll be more of asking counting and stuff like that. And as they go towards the Wernicke's, they'll start asking more of comprehensive type of questions like, where are you from and what is your relatives' names, and they will ask them to tell there's vocabulary of the words like constitution and things like even which we cannot pronounce. So they make the patient pronounce all that, and that's how they go about it. And usually it's done in intervals, and it's done in a semi-formal way because it gets irritating to the patient actually if you keep on asking the same questions. So we tend to have a informal conversation also in between, and the surgeon also will be talking to the patient about his family or something like that, and that's how it goes about. And the formal set of questions will come in intervals, and most of the time we'll be engaging the patient in a semi informal conversation. And if it's in the motor area and all that, we have a electrophysiologist. I mean, we'll see the SSEP, and we'll see for the phase reversal and all to identify the motor cortex, and also the direct stimulation during the time of motor assessment. So that is how we go about in our place. And sometimes if the patient gets too irritable, we'll titrate the dexmedetomidine to a 0.1 to 0.3. I mean, we'll just keep so that he is in a natural kind of sleep and wakes up, especially towards the end of the procedure. That's when they tend to get more irritable. So they also will keep on asking, is it over? Is the tumor out? Are we done? So that's when we restart the dexmedetomidine at a very low level, and we tide over the crisis at that point of time.
Okay, when the patient is awake, do you think it is important to use SSCP or MEP, because when patient is awake, he himself is the best monitor.
That is there. This is just they're just being doubly sure about the thing. I mean, it's just that we have the thing, so why not use it? I mean, so that
but
they identify the motor, because sometimes in gliomas and all, no, the anatomical neuroanatomy will be altered, so they're not really sure where the gyri sulca is, and I mean, have they crossed the central sulcus? So just to identify the Rolandic stuff and all that, they use the phase reversal. And once they know that they are in the motor cortex, then they individually stimulate the areas, so the hand area, the speech, the face and stuff like that. So that's when the second stage of individual cortical stimulation starts. But first they will go for a gross identification of the motor area with the phase reversal. And once they are sure that they are in the motor cortex, they will go with the individual this thing. I mean, Shobana ma'am, in your center, in your MRI suite, do you actually combine neuro monitoring, or is it like pure MRI, or do you have neuro navigation or
Yeah,
stuff?
we combine neuronavigation with MRI, and if they do need SSEPs or MEPs, then neuromonitoring is called.
Okay.
They are called if necessary.
Okay, like when you use neuronavigation, I mean your osmotherapy and all this, does it affect in your thing, because the images will be done in a awake patient, and does your the field shift happen with your ventilation or your osmotherapy?
It could happen. I guess that's the reason why they do the MRI also. Most of the time, we do give some sort of osmotherapy just before waking up. So, and after that, they do the MRI scanning after the resection. So maybe they are able to detect if there is any shifts. Do you all have any other tricks or tips for brain edema? If the surgeon tells that the
Am I
brain is
audible?
tight.
Yes, yes, sir.
Do you have any
Okay.
other techniques for that? If they say, if the surgeon says the brain is swelling and the patient, it's a sleep awake, a sleep technique, what would you do?
I usually ask the patient himself to hyperventilate for some time. Sometimes
Mm,
when he take deep breaths,
yeah,
Right.
then sometimes help. Other than that, we give manitol. And in awake
mm,
craniotomy, because we take the patients who do not have very large tumors, so
yeah,
that we have till now not faced even a single problem where
yeah.
we had to abandon the technique or we had to reintubate the patient. It did not occur.
Yeah, I feel like it's more common, especially with the obese patients, because it's possible that they are already having shallow respiration. So the ETCO2 many times is 45 or above sometimes.
Yes.
Because of network issues, Ponniah has not been able to.
No, that
Yeah.
that is a, what about this urinary catheterization? Do we routinely do it? Because
Yeah.
I personally feel that every case, at least I ask them to catheterize, because issues like this, when there is a edema or something, I am at a liberty to give mannitol. And after 3 hours or 4 hours, because these patients are not used to that AC of the OTs, generally they ask for voiding urine and all. So if you are not catheterized, so I personally insist on every case to put urinary catheterization, though it may be slight discomfort to the patient, but I feel at least I am comfortable in that. What is the opinion of the people who are here? What
We
about
do.
you, madam, Shobana madam?
Yeah, we always put in a urinary catheter.
Yeah,
You
okay.
always know that. I
Oh,
totally agree with you on that.
yeah,
Patient is also
We,
comfortable.
yeah.
Yeah.
we
That's,
also put catheters all the
mm,
time because the patients are
mm,
more comfortable with catheter than without.
yeah.
Though
Sometime, yeah,
the,
yeah,
the, the, the patients generally we are more comfortable with catheterization, number one,
mm,
because then we don't feel like that we have to restrict our hands to use mannitol, etc. For
mm,
the patient it's an indirect comfort because he doesn't know that he has to be here in the OR for a long time. But in the beginning the patients keep on complaining that they are not comfortable with the idea of catheterization, with the catheterization per se, and with the catheter in situ.
yeah,
So, but we catheterize all the cases, and we
yeah,
have to console the patient and tell them frequently that everything is all right and they can void easily through the catheter.
yeah.
Do you
Are
need
you
to
people?
catheterize after the scalp block and once the full dose of dexmedetomidine has gone through? So very rarely,
We do that,
like
but
very rarely,
still
yeah,
we face this problem. We
yeah.
do sedate the patient before catheterization, but even after the surgery and sometimes when they're awake, they complain of the discomfort of being catheterized. I don't
Yeah,
know if it is seen by everybody, but we often encounter. Sometimes they say that they want to go to washroom and they are not able to void. We have to repeatedly tell them that you are catheterized and you can easily comfort yourself.
The
Mm.
no,
other option is condom catheters for male patients, which anyway they are awake, they can void and it can be gone. Um, but for females, yeah, of course, you will have to.
Right.
When we are doing awake craniotomies, we routinely combine it with neuronavigation and the ultrasound, and we find it works well for our patients actually. That what is the extent of the tumor resection and all the other stuff. Because if you find there comes some weakness, then invariably surgeon will abandon the rest of the resection, right? So we generally combine with neuronavigation and the ultrasound. Do you still, Shobana madam, use the neuronavigation when you plan the intraoperative MRI?
Yes, yes, we do. We
Yeah.
do both. Yeah.
So,
We combine
so
the two.
we
Yeah.
are now combining even the ultrasound, and we have the system where even the ultrasound can be combined with the navigation. So it will show you the probex where it is placed and all those things. So it makes still more comfortable for us, so that the shifting of the patient to the MRI suite and all those things are avoided. But particularly, I am more going towards totally awake, and totally awake as far as patient is comfortable. Particularly, I find it more useful when the patients are young and able to understand what are you trying to tell, and what are the advantages. You will be able to communicate. So
Yeah.
old age, it is like a double-edged sword. You give more, then they will go into apnea and respiratory problems. You give less, they may not be comfortable. That's the issue. So how do you proceed? Like particularly if the surgeon insists on awake craniotomy on a patient who is 60 years, 70 years, are you comfortable doing it, ma'am?
Oh yeah, we
Yeah.
do commonly get those kind of patients, and
Okay.
and they do want the patient to be completely under, because they wouldn't like the patient moving, especially even when they do the scalp blocks and things like that. So we do bolus with propofol at those times, and even
Okay.
during urinary catheterization, we bolus propofol.
Okay.
Obviously, patient could stop breathing for a bit, but
Hmm.
then they do resume. So it is a sort of control situation,
Yeah.
but it's doable.
Yeah. But how do?
Ma'am,
Yeah, Ajay.
how do you manage the analgesia component other than scalp block? Do you have any other adjuvant analgesics? Do you use intraoperatively and postoperatively?
Yeah. I didn't mean to mention that. That's a great question. And yes, we do give IV Tylenol just prior to the awake phase.
That is
So that's the analgesic we do, besides giving some amounts of fentanyl. And of course, a scalp block.
Yeah.
Do you do anything else?
No.
yeah. We also give paracetamol and
Okay.
post we give morphine.
That's in the post-op, you mean?
Am I
Morphine.
audible now, Dr. Prana?
Yeah.
Yes.
Yeah.
Yeah, I'm really sorry. There was it's raining here and the disruption. And Dr. Shobana, I think questions are happening in the live chat as well. And people are wondering whether you can do in other positions also awake craniotomy and in an MRI suite, like lateral or maybe have you tried other positions, or it's only supine?
No, it's most of the time lateral. Mostly they put in, if it's on one side or the other side. Like suppose it's like a left cranny, then they put a roll on the left side, and the left side has to be up. So obviously the patient is turned to one side and the head is pinned and positioned to one side. And then you have to put in the LMA also. It's all very tricky. But yes, lateral positions are possible in addition to supine. Obviously, we haven't done prone, but we do lateral and supine. Yeah. Yeah.
Okay.
Yeah.
So I just want to ask you another question as well. Only use antiemetics?
Oh, yeah. Routinely, we use antiemetics. We use ondansetron always. And I always give it in the first phase so that when the patient wakes up, they're not retching due to some reason.
Yeah,
I
especially
suppose
during
all
the
of you do that.
pool and if they're using opioids, they have nausea.
Yeah,
Especially when
totally.
pulls the dura, they'll
Yeah.
have the nauseous tendency.
Yeah. Do you all use ondansetron also?
Yeah, we do.
Yeah, routinely. Yeah.
Yeah.
Okay. So I think today we had a wonderful discussion, and I must thank Dr. Rajan for coming and present a very excellent, and we are very, and I think to our faculty and all the viewers, and we are going to take it forward with other interesting discussions in the coming classes. I hope you'd find some time to come to our classroom again, and we'll continue the discussion in groups. Thank you, Dr. Shobana, for coming and joining this classroom. And I thank you so much. And thank other faculty as well, Dr. Prasanna, Dr. Manish, Dr. Gopal Krishnan, Dr. Ashish, and Dr. Ajay. Thank you so much. I think it was a very, very interactive and an interesting discussion and an interesting case as well, which many might not dare to do in a week. So thank you so much, ma'am.
Thank you so much for having me. I think you're all doing a great job with this neuro classroom.
Yeah, thank you. Thanks a lot.
Thank you. Thanks all for watching this. We'll meet in a different case scenario. Until then, bye-bye. Have a nice day and wish you all a very happy holidays and a happy new year. Thank you.
Yeah,
Thank you. Thank you.
Thank you.